Hello, dear colleagues. Welcome to this webinar of the EANS functional section, where today's experts will discuss neurosurgical treatment options for temporal lobe epilepsy. And with me, I have Dr. Karl Rössler, head of the department in Vienna, who will discuss surgical approaches for temporal lobe epilepsy, and Dr. Olaf Schijns, who is chair of the functional section, and he will share some lessons from 2 clinical cases. One important thing before we get started, I want to encourage you all to actively participate by writing down your comments and questions in the Q&A box. We have a discussion after the first as well as after the second lecture, and you can pose questions at any time, and I will check these regularly. So let's go.
Dear colleagues, thank you, Tom, for the kind introduction. My topic for today is temporal lobe epilepsy and surgical approaches. Yeah, my agenda will be some historical remarks at the beginning, the surgical temporal lobe resection techniques, the surgical strategies according to the different pathologies. Then I will have a look together with you in the literature about temporal lobe resection versus selective amygdalohippocampectomy.
Karel, your
I will
presentation is not
summarize.
there.
Pardon?
Your presentation we cannot see yet.
Okay, it's open already.
Now you have to share your screen.
Niemeyer, a neurosurgeon in Brazil, described it 58. It can be done transsylvic ventricular. Yashagil, who is a well-known vascular neurosurgery, he pioneered this approach because he clipped many MCA aneurysms, and he realized that it's only a small way to the ventricle. And so he pioneered this transsylvic ventricular resection of the mesial structures. Schmiedek, it was also a byproduct of aneurysm surgery. He realized that the anchors can be resected by widely opening the cistern and also getting into the ventricle by resecting the anchors. The subtemporal approach to the mesial structures was pioneered by Hori in Japan in the early 19th, and the supracerebellar transtentorial approach by Yonikawa in the early 2000s. But this approach is only very rarely used, maybe for some temporo-occipital mesial lesions, which are not really reachable from supratentorially. The next point I want to highlight is the surgical technique. Here is the opening of a right-sided temporal lobe. Here's the Sylvian fissure, the frontal lobe and the temporal lobe. Here you can see the T1 gyrus of the temporal lobe. Next step would be corticotomy at the T1, very close to the pole. And this is more or less the Spencer technique. 2 or 3 centimeters of the pole are resected without opening the ventricle, but with resection a little bit of the anchors. And here you can see on the right side the temporal fossa. The next step is then opening the temporal horn within the temporal white substance. Here you can see the open horn. And what you also can see here on the right side is this is the amygdala. It is very close to the temporal horn. And you can resect the amygdala then and also go to the anchors. And if you remove amygdala and anchors, you can see here the tentorial edge, the oculomotor nerve, and the ICA, the carotid artery. And then you can go behind to the plexus and visualize the fimbria hippocampi. If you lift the fimbria and cut the fimbria dorsally, like here in the middle picture, you can see the parahippocampal gyrus. And by going into the parahippocampal gyrus, you can subpially remove the parahippocampus. And what you can see here is this trigonum terminale. It is where the fimbria, the most frontal part of the fimbria, and if you lift this trigonum terminale, you visualize the mesencephalon, the anterior side of the crus cerebri. And then you have almost disconnected frontally, then over the mesencephalon, and dorsally, here on the right side, you can see the coagulation of the hippocampal vessels coming from the BCA, from the posterior cerebral artery. And the next step is then cutting the dorsal hippocampus and superiorly removing the parahippocampus and on top the hippocampus. And by doing that, you have this nice operative specimen which can be investigated by your neuropathologist who can tell you what kind of hippocampal sclerosis or hippocampal lesion it is, which may have some implications for the prognosis of the epilepsy. And this is a small video where the same steps which I already showed can also be visualized. It's also a right-sided temporal lobe. Here's the T1 and a right angle to the temporal base. You can see here is this is the pole specimen, 2 or 3 centimeter of the pole. Here, the horn is here already opened. You can see the head of the hippocampus. And here's the resection of the anchors. And by resecting the anchors, you are superly ending in the cistern. Here you can see the oculomotor nerve comes into visualization, the dentorial edge, and mesially the ICA. And if you lift the trigonum terminale, or if you go through here, through the anchors, you can visualize the mesencephalon. You have already seen the BCA. Here's the fimbria, which is also cut. Here's the mesencephalon, this trigonum terminale. And you can do it from anteriorly or from posteriorly. Superiorly, you can remove this specimen as a block resection of hippocampus and parahippocampus. Yeah, this is the place where if you go up along the MCA, you are coming to this piriform cortex. Yeah, I think this is the end of the resection already. Yeah, and you also can do that by using neural navigation and virtual augmented reality. If you have a microscope which can do this, and there you can maybe a little bit more controlled do the resection. And what you also can spare maybe more sufficiently is the optic radiation. You can include the fiber tracts of the optic radiation, which you can see here. And if you track your microscope, you see how far you can go behind without injuring the optical radiation. And this is maybe essential for the patient because this upper quadrant opia is avoided. Here are the steps we already have seen. Here is the BCA, perimesencephalic vein, and the parahippocampal gyrus. And here's the block specimen. And why is temporal lobe surgery so dangerous? And why is stroke a feared complication? This is maybe best thought about if you see this anatomical preparation from Johannes Lang from Würzburg. He was a very famous anatomist. And what you see here is the mesencephalon, the BCA, the ICA, the PCOM, and the choroidal arteries. And this is exactly where you end if you resect your parahippocampal and gyrus and hippocampus. And you have absolutely to stay subpially, not to injure the pia to these important vessel structures, because otherwise you risk to have a stroke, especially if you injure these choroidal branches of the carotid artery. And these are, by the way, the complications: visual field deficits, especially upper quadrant anopia of the contralateral side. It is in modern series, it's about 10 to 15%, but there are also series where it goes up to 50 or even 80%. Then you can injure the nerves, the third and the fourth nerve, You can have a meningitis in the dominant side dysphasia. Hemiparesis risk is about 1 to 2%. Subdural hematoma mortality normally 0 in the modern series. Then very important surgical strategies according to pathology. When to do a more extended resection and when to do only a selective resection. This is maybe best answered if you divide your epilepsy in lesional temporal lobe epilepsies and non-lesional MRI negative temporal lobe epilepsies. The lesional epilepsies are very straightforward. You have lesions like cavernoma, cortical dysplasia, layered long-term epilepsy-associated tumors. For that, you can do lesionectomies. If you have intraoperative electrocorticography, you can maybe decide to take more than the lesion if you see spikes around. But more or less, for these lesions, there are only lesionectomies are indicated. For hippocampal sclerosis, you have to look at your PET in the preoperative investigations. If you have a hypometabolic state in the temporal pole in your glucose bed, it is better to use an anteromesial temporal lobe resection, which means the Spencer technique, taking the bowl, which is sclerotic and hypometabolic in the bed, and taking the mesial structures. If you have a normal PET and only hippocampal sclerosis, you can use a selective approach, a SAHE, a selective amygdala hippocampectomy. For laser ablation, it is controversially discussed, and I want to go in detail with that. But if you have an MRI negative temporal lobe epilepsy, you can decide maybe to do further invasive monitoring using stereo EEG to think about taking the whole temporal lobe or only parts maybe. But if you have no hints and if you are not able to use stereo EEG, you have to do a large resection, which means temporal lobe resection on the non-dominant side for maybe 5.5 centimeters, including the mesial structures, and on the dominant side, 4.5 centimeters is recommended. And from which why I'm telling this so or I'm stating that because there is much literature about that. What is best to do in such cases? And this is my next point, which I wanted to discuss. There is a very nice systematic review, which was published 2013 by Wiebe et al., the group from Montreal, who did also the prospective study on temporal lobe epilepsy surgery versus medical treatment. And they did a systematic review and meta-analysis and comparing anterior-temporal lobe resection versus selective amygdalohippocampectomy. And what they found was that in most papers, in the analysis of the papers, the anterotemporal lobe resection had an 8 to 10% better seizure outcome than the selective resections. And in the same year, a Chinese group, interestingly, published the same analysis. And they, of course, got to the same conclusion that SAHE has a significant reduced chance chance of seizure freedom compared to anterotemporal lobe resection. I emphasize to take the temporal pole, especially in cases where there are PET abnormalities, hypometabolism in the glucose bed. And there is a very important paper to my mind from Grenoble, from the Benabit and Kahane, from Kahane group. And they stated already nearly 20 years ago that the resection of the temporal pole is key for favorable seizure outcome, because it is involved in so many aspects of the temporal lobe epilepsy. And another very important paper from the Montreal group, where at this time André Olivier was the surgeon there. They compared different approaches or strategies, and they came to the conclusion that both selective and the more extensive resections can lead to similar rate of favorable seizure control. And what was in some papers not considered was the neuropsychological outcome. And many epilepsy surgeons in Europe, they are more or less pupils of Johannes Schramm in Bonn. And what Schramm in his papers, together with his neuropsychologist, stated was that the selective amygdala hippocampectomy has similar seizure control and outcomes compared to the temporal lobe resections. But in his series, he found that these patients had a better cognitive outcome. And again, the Montreal group investigated these different approaches, also coming from the neuropsychological side, or testing the neuropsychological outcome. And they also compared these two strategies, and they found that both can lead to severe cognitive impairments. And this mainly depends on the site of resection, which means if you operate on the dominant side, no matter what you do, doing only a selective amygdala hippocampectomy or a temporal lobe resection, there may be bad outcomes. Another paper from the Kahane group, Rivellin and Kahane, which is very important for temporal lobe resection and indication for the resections, is that in MRI negative patients, you always have to be aware of that it may be, they called it temporal plus epilepsy, which means that the insula may play a role for the epilepsy, not only the temporal lobe. And this is maybe one of the main reasons why we should think about doing a SEG, a stereo EEG, in patients with temporal lobe epilepsy who are MRI negative. Another maybe important paper from the Danish group is this one. It was published 2018, and it said that SAHE leads to sustained seizure freedom and also a better memory function. And there are two papers which I also want to mention. They are coming from Freiburg, from Josef Zentner and his group. One was he compared different approaches and came to the conclusion that they have similar epileptological, neuropsychological results and complications. And interestingly, in the same year, he published another paper about SAHE patients, and he stated that SAHE can be recommended as an adequate procedure for temporal lobe epilepsy. An important paper you might know is the paper about the piriform cortex. I don't want to go in detail, And this is the paper from the group in Vienna. At this time, I was in Erlangen, but these are the patients from Thomas Czech. And there were 150 plus patients. And the conclusion of this paper was that SAHI gives a satisfactory long-term seizure outcome, but the neuropsychology was not considered in this paper. This paper were the patients from Erlangen, which I published, and we came to the conclusion that anterotemporal lobe resections significantly more completely seizure-free patients. And interestingly, what we found was that in non-dominant patients, the verbal memory improved after resections. And the last paper I want to state is the temporal lobe epilepsy surgery in children. And here it came out from not only from this paper that anterotemporal lobe resection is more successful in children than selective resections. And so I want to wrap up my talk. Anteromesiotemporal lobe resections have a better seizure outcome in mesial temporal lobe compared to SAHES and gave a better surgical overview and maybe also less complications. Selective techniques have around 8% less successful in epilepsy outcome. Neuropsychological deterioration depends more on the dominance of the resection site than on the surgical technique. The piriform cortex resection leads to a significant better seizure outcome, and in pediatric temporal lobe epilepsy, temporal resections give a significant better seizure outcome. Thanks for listening, and the paper is open for the talk is open for discussion.
Okay, thank you, Carl. I will check some questions. One question is about what is your strategy in case of failed temporal lobe epilepsy surgery and the histopathology of hippocampal sclerosis? What would you do in that
we
case?
normally do a epileptological re-evaluation, and if the seizures still came from the same temporal residuals of the temporal lobe, we consider a resurgery. In some patients, we see that the other side starts to develop seizures. In these patients, we now consider to use these easy implants, these Boone stimulation device, which was designed.
For the epicranial stimulation.
Yeah, epicranial stimulation.
Where we would probably go for ANT DBS, which would also be an option, I guess, in these cases, or VNS, but indeed in bilateral cases, I would refrain from surgery, in my opinion.
But primary reinvestigation, maybe resection. And the Vienna group also published a paper on patients which were reoperated, and the outcome was still 50 to 70%.
Of course, one has to take into account that even if there's histopathology of hippocampal sclerosis, there could be another lesion. There could be a cortical dysplasia, or there could be even an insular trap that has been missed. And that's why you have to reinvestigate to make sure that, it is that the whole of the epileptogenic zone has been removed.
Especially in selective operated patients.
And this question is one you will like, I guess. Which cadaver course, according to your opinion or personal experience, are best to study epilepsy surgery?
Which course?
Which cadaver course?
Cadaver course. Maybe our cadaver course in Vienna, which will be held from the 22 to 24 August this year. But unfortunately, all places are booked out.
And then the next question is about PET changes in temporal lobe epilepsy and hippocampal sclerosis, either using FDG or flumazenil, maybe extensive, which is true. You often see very extensive PET changes and not pointing exactly at the seizure onset zone. Would you aim to remove most of the PET hypometabolism or perform a standard Spencer resection?
In temporal lobe epilepsy, I would resect all the PET hypometabolic temporal lobe. So this also can be a standard temporal resection. So these 5.5 centimeters non-dominant and 4.5 dominant.
Okay.
Because the hypermetabolism in PET means that the whole temporal, normally you see the hypermetabolism in the pole, and during surgery you can see that it is sclerotic, yeah, and yeah, you have to remove that.
Yes, but only the pole, I assume. I mean, sometimes you have these very extensive posteriorly extending or more extensive PET hypometabolic zone. Of course, you have to be careful not to miss, of course, a dysplasia which is located more posteriorly, which is related to the PET hypometabolism. But I would assume that you not always resect the whole of the hypometabolic zone on the PET because it's not related to the seizure onset zone in any case.
Yeah, if I'm true, I don't see so many extensive hypometabolisms in temporal lobe. I normally only see the pole hypermetabolism.
Yeah, Olaf, would you comment on this?
Yes, so that's correct. I would not strive to take everything out from the hypometabolism, but our strategy is from the working group that when you have a hypometabolism and something of the temporal lateral neocortex is involved, do a standard or even maximal temporal lobectomy plus the mesial structures.
Yeah, you say plus the mesial structures. Well, we sometimes do cases where there is no hippocampal sclerosis on the MRI, and there is PET hypometabolism. And there have been papers showing that if you resect just the uncus and the temporal pole, these patients also do pretty well. But some do evolve into a hippocampal sclerosis on a second stage. Sometimes years after the resection, you can get a secondary sclerotic hippocampus.
Yes.
But,
no, you are right, and I will show the second case of me is more or less in this case. Yeah.
Yeah, Carol, maybe one more.
Maybe in these cases, a stereo EEG should be also considered.
Exactly.
If you have really an MRI negative and some abnormalities in the PET, you don't really know what it means, and there's always this temporal plus epilepsy problem. Maybe the insula is involved, and so you can also do insular electrodes if you do SEEG. Maybe this could be considered in such cases.
Yeah, definitely. If something is off, for example, in the clinical picture, like patients have these laryngeal spasms, or if the EEG is not typical, one definitely has to go and do SEEG and make sure that there is no insular trap or any other temporal plus epilepsy. I have one question for you, Carl. Maybe for the listeners, it would be interesting to discuss also how you position the patient. You nicely and eloquently described how you resect the hippocampus.
Yeah.
Maybe one more remark. You, of course, have a lot of experience and you do an en bloc resection. For people who start with epilepsy, sometimes it's easier to do, like not an en bloc resection because it might be safer in the beginning, or easier at least. It's more important to spare, in my opinion, the pial plane or the arachnoid. But just about the position, how do you position the patient? And maybe I missed it, but...
Normally, the thorax is about 30 degrees up. The head is turned 60 degrees to the contralateral side. Do you see the patient's
yes.
head?
Mm-hmm.
Yeah, and so I position it like that.
Yeah, some people advise to do like some posterior tilt of the head if you have to go posteriorly in the hippocampus, or do you not go for the posterior tail of the hippocampus, or what is your opinion on this?
But the plane is a little bit down. Yes, the vertex of the patient is a little bit down, but you can also position your microscope. You can bend and your microscope, so tilt your microscope so that you can see up. Yeah.
Okay.
Yeah. And so, Karel, I think there are some variations described. I see here you have a kind of, you have shaven the hairs for a question mark incision, but
Yeah,
you could also use a linear incision
yeah.
from the zygoma up.
I always use the large incision because I normally don't shave so much hair. And if you use this kind of incision, it is totally covered by the hairs. And if I used sometimes I used linear incision, but the problem is that you are not able to go to the pole, and you don't see amygdala and the anchors so good if you don't have this large flap where you can go down with the craniotomy and so on. If you want to do only selective amygdala hippocampectomy, a linear incision is absolutely good, yeah, because you can go transcortically in the ventricle and remove the hippocampus and parahippocampus. But if you want to do a pole resection and also more extensive resection, I think the flap is better.
Yeah, definitely. If you want to do a tailored dissection, you have to go posteriorly. Yeah, I think I use a straight one, but I think it's not that important in a sense. Okay, thanks so much. I don't know if there's any more questions. I'm going to check. There is one more question. Yeah, how much of the hippocampus do you aim to remove? Yeah, this is a big discussion, or has been a discussion at the Schramm time. He wrote a paper on
2.5
this.
centimeters. My standard resection of the hippocampus is behind the mesencephalon, so that I can see I can see behind the mesencephalon. Yeah.
Okay.
It's normally 2.5 or 3 centimeters. Ambient cistern.
So do you measure it? Because
You subbarely see the ambient cistern. Then you know you are right.
yeah. So you see the lateral geniculate, and then you
Yeah.
often see this tail turning around the thalamus, and that's more or less where you probably stop your resection. But so you do go more posterior than some other surgeons who tend to remove the head and part of the body, and they just say this is probably enough. I think the jury is still out on this. I don't know what you do, Olaf. What is your opinion on the extent of resection of the hippocampus?
Yeah, I was trained. I was trained for the epilepsy surgery in Bonn, and in those days, the publication of Schramm came out 2.5 versus 3.5, and there was no difference in seizure outcome. So what I normally do is I use the Spätzler bipolar forceps, and when you have the two legs of this forceps in a relaxed state, this distance is 1.6 centimeters. And that's a very good way to measure your hippocampus. So you put your Spätzler forceps on the hippocampus in a relaxed position, and then you can exactly measure the distance intraoperatively. So you can also use this, of course, what is shown, but we use it with the forceps. And exactly what I'm learning also the trainees in our institute is I try to see with the navigation when I'm behind the broadest part of the brainstem. And when I'm behind, I perhaps turn the microscope and look into the ventricle if I see something remnants of the tail, and go with the CUSA and take that also away, and that's it.
So at the lateral mesencephalic sulcus, and then you just have a look around the corner if there's any easy, removable tissue left. Okay.
Yeah. Yeah.
Any more comments? Otherwise, we go to you, Olaf, with your presentation. I think we responded to all the questions.
Okay. Let me see. Can we close this?
Stop sharing. Okay, I have stopped my sharing.
Let me see. I I don't see now my own screen.
Normally, there's a ruler on the bottom, and there is this button, share screen.
Ah, we have one more question. Sorry, there is one who didn't post a question in the box. So, good evening, sir. What is your experience with MR encephalogram? MR negative. I don't know.
MEG, maybe. Magnetoencephalogram.
Ah, MEG probably. Yeah, it's probably a MEG in
We
temporal lobe epilepsy.
yeah, we had a MEG in Erlangen, or they still have it, but I used it at that time when I was there. And in temporal lobe epilepsy, it was not so useful. It was very useful to find extra temporal epileptic
Dysplastic. Yeah.
zones in MRI negative patients.
True, that's where we also send the patients, for MEG if there is cases where you don't have or you cannot find clear dysplasia, and sometimes these spikes can tell you, well, where to look for. Olaf, we're still with a black screen. And you're mute.
Olaf, your microphone is muted.
You're muted.
Yeah, but I don't see my own screen.
Okay, Olaf, best if you could just start over. So stop sharing, have your PowerPoint with the presentation opened, and then share again. Let's try that. Okay, we see your presentation, and if you could just play a slideshow.
Do you see it now?
Okay, fantastic, yes.
Okay, thank you.
Thank you.
Well, nice. Thank you, Tom, for your kind introduction, and Carol for your nice presentation. Just for the listener who asked the question, which course to attend? Well, indeed, we took from the functional section the initiative to organize an epilepsy surgical course. This is fully booked, that's correct, in Vienna in August, but we intend to organize this course every year. So please inform yourself on the website of the EANS on our functional neurosurgery section site, and there you will have new information about upcoming courses. Okay, well, I will go on with the lessons from two interesting cases we had. As you know, the number of easy patients, so meaning a clear hippocampal sclerosis and a clear video EEG supporting the diagnosis of a temporal mesial epilepsy, well, those patients are still there, but we get more and more complicated patients, difficult patients, meaning patients who have, for example, a negative MRI scan. And I would like to show you two cases we had in our center. Well, I recap a bit. That's always good. Temporal lobe epilepsy, it's of course the most prevalent subtype in chronic drug-resistant epilepsy. And 30 to 40% of those patients are drug-resistant. Well, we have a kind of phase structure in the trajectory for selection patients or for epilepsy surgery. The phase 0, we call it, that's a quick scan. So the neurologist in our center is scanning within 1 week if a patient can go into the epilepsy surgery program or not. And the patients who enter in there, that are patients from the peripheral Dutch hospitals, when neurologists are doubting about a patient with epilepsy. So they can send them to our epilepsy center, and then we have the phase 0 started. Well, from phase 0, you go to phase 1, and that is you make a 3T MRI. There is a review by a neuroradiologist interested in epilepsy, educated and trained in epilepsy, and you have a special epilepsy dedicated MRI protocol. So when that renders most of the patients, well, that gives the best chance, let me say it like that, that you will find a lesion. Still, about 25% of the adults and 33% of the pediatric population is MRI negative. At the same time, we do a video EEG, that's a scalp EEG, and we do the neuropsychological examination. Well, when you have the easy patients, you can go on and go directly to phase 4, the phase epilepsy surgery. But the more difficult patients, where it's not so clear, you go to phase 2. And phase 2 is still non-invasive. In this phase, you could use a SPECT scan, a PET scan, a MAC, or EEG fMRI to support, to get more support for your hypothesis where this focal epilepsy comes from. Also from this phase, when everything is clear, you can go to phase 4, that's the surgery, or you go to phase 3. And that's an important one, I always tell my patients, because then you go from non-invasive to invasive. And then you have the invasive EEG possibilities by doing a stereo EEG. I think nowadays that's 80 to 90% in our center. Or you use surface electrodes because they are always valuable in certain cases. Well, when you come then in phase 4 in the epilepsy surgery spectrum, how does it look like? You have the curative part and you have the palliative part. About the palliative part, we now do not discuss. The curative part, well, we heard the nice lecture from Karl Rössler about open surgery, the anterior temporal lobectomy, with or without the mesial structures, lesionectomies, hemispheric disconnections, all with a curative intention. Upcoming minimal invasive techniques like the SEEG thermocoagulation, MRI-guided LIT, and the high-frequency focused ultrasound, and also non-invasive procedures like stereotactic radiosurgery. Well, my first case, I would like to present to you a young female adolescent from 14 years old, and the debut of her epilepsy was on 12 years. So she had 2 years epilepsy when she came to our center. And she had the following seizure semiology. Her first seizure type was lasting about 30 seconds daily, more 3 to 4 times. And she was smelling something which compared to burnt food. So like when the meat is too long on the barbecue. And the taste, she had a metal taste in her mouth. She had also a feeling of anxiety. So there was nothing to be anxious about, but at those moments she was anxious. That was the first type of seizures. And then she had a second type. She had also the same olfactory, but also gustatory auras, followed by orofacial automatisms and a decreased awareness. These types of seizures took 1 minute, and she had that more or less 1 time a day. Well, the epilepsy from this patient was drug resistant. Her medical history was unremarkable, and we always ask for epilepsy risk factors like febrile convulsions, trauma, meningitis, or a positive family history for epilepsy. Everything was negative in this case. In the neuropsychological examination, they discovered that she was left-handed and that there was also left-handedness in her family. Her mother was left-handed. Well, the proposal of our epilepsy surgery conference was start phase 1. And then you see this MRI coming up. This was a 3T MRI, an epilepsy dedicated protocol with gadolinium. And you see here, when I go from the upper left corner, that's a T1 without contrast. Then you go to a flare below it, a T2 in the right upper corner, and a T1 plus contrast in the right lower corner. And you see there that there is a mass lesion. It's quite well circumscribed, sharply demarcated, hypo-intense on T1, hyper-intense on T2 and flare. And there is a contrast enhancement. So the conclusion of our neuroradiologist specialized in epilepsy was this is most probably a long-term epilepsy-associated tumor or a low-grade epilepsy-associated tumor, a Layard tumor, most probably a ganglioglioma because of the position in the temporal lobe and the contrast enhancements. By the way, you also see a arachnoidal cyst in the left temporal pole. So this was the MRI of this patient. The video EEG showed interictal and ictal epileptiform activity on the right anterior lobe. And there was no clear, finding about temporal mesial activity. That was not clear on the video EEG. She had a neuropsychological examination, of course, left-handed, the family also left-handedness, and she had no cognitive malfunction. So especially her memory function was completely normal and age appropriate. Well, what was the decision of our management conference? Let's do an extended lesionectomy. That means the temporal pole, the lesion, uncus, the lateral amygdala, but without a hippocampectomy because of her good memory results in the neuropsychological examination. I normally use, when it's not a maximal temporal lobectomy, I use a straight incision starting here above the zygomatic arch, sometimes curving a bit to anterior, because you need sometimes a burr hole here in the keyhole. And then you have to spread the sometimes large temporal muscle in order to reach the keyhole. But normally that's no problem in my opinion. So, and also making the linear incision, this shortens a bit the operation time. Well, we operated this. We took out the temporal pole plus lesion without hippocampus. And this was what our neuropathologist was showing. We have once in 2 months all our histology shown by our neuropathologist dedicated in epilepsy. And he told us it's a ganglioglioma, WHO grade 1, CD34 positive. That's a quite special marker for gangliogliomas. BRAF V600 positive, which is seen in up to 60% of gangliogliomas. The meaning of the BRAF mutation is not very clear at the moment, but it could be. There are some publications that those patients with the mutation have a higher recurrence rate of tumor. So this was this pathology in this young lady. And what happened after the operation? Well, the direct postoperative status was good, no neurological deficits. She is now since 4 years seizure-free, and since 3 years she is without anti-seizure medication. She had a control neuropsychological examination which was unremarkable and unchanged compared to preoperative. And we do a follow-up MRI brain each year for the first 5 years, and thereafter we extend the scan interval. But I don't think there will be a recurrent tumor. So in our opinion, this was a good decision, especially to spare the hippocampus because of her quite good memory status. And well, it appeared to be that she came into an Engel 1 score after surgery. Then the second case, also a patient, but a lot older, 49 years old, male. His debut epilepsy was on 43 years old, so quite old for an epilepsy patient. And this patient had 3 types of focal seizures. He had nocturnal seizures, so he there was an awakening from sleep with a pressure on his chest, followed by a sensation as if his throat was being squeezed. This seizure took 30 seconds, and his partner noticed a decreased consciousness during these moments and snoring breathing. The second type was a sudden feeling of being in a dream world and maybe perhaps a bit absent for a while. Sounds in his environment were very loud. He perspires and was shaking, and those seizures took about 10 to 15 seconds. And there was a third seizure that was a period of sudden absence, so he was not reacting, and he had a loss of strength of his right arm. This also took 30 seconds, and afterwards he had he speaks gibberish. So in German you say Wortsalat. So he was talking, but it was quite it was not very clear. Well, this just to show that he was drug resistant. This were the actual anti-seizure medication he was taking daily. We did the phase 1 evaluation. The video EEG was congruent with a focus in the left temporal lobe, or perhaps primary insular region. And when you combine this with the semiological symptom which he had of squeezing the throat, which was Tom just announcing, that should bring you on the thought that it could be an insular focus. But, well, the video EEG was not specific enough. Then we did a 3T MRI. There was a questionable abnormality of the left amygdala. Well, we were thinking, okay, this anxiousness, which the patient was describing in his seizure, in one of his seizure types, could be associated with something from the amygdala, but we were not very sure. And this looked like this. This was the inversion recovery coronal slice. And I don't know if you see my cursor, but here on the left side, there was a suspicion that this amygdala was a bit bigger than on the right side. But the neuroradiologist was a bit doubting. We don't do volumetry in our center, so it's just a subjective appreciation of the scans. This was the same patient with the flare. And there you see also with a question mark, is this a bit more hyper intense than on the other side? Is it a bit more enlarged than on the other side? You also see that the ventricle here is a bit more enlarged. So it was questionable. We had the neuropsychological examination, and altogether the impairments in expressive language skills correspond to the neurophysiological abnormalities in the left temporal regions. So the neuropsychological examination also pointed a bit to the left temporal region. We did a PET scan, and this PET scan showed a slight hypometabolism in the left temporal mesial region. We did a magnetoencephalography, and this showed evidence of left neocortical temporal involvement, but also left hippocampal involvement. Well, it's now clear that phase 2 was helping a bit, but our decision was that we could not yet go to phase 4, and that's the surgery. Therefore, the advice to the patient was to start phase 3. Let's do a stereo EEG, especially with a focus on the left temporal lobe and the insula. Well, we follow the French guidelines for stereo EEG, and we implanted 8 depth electrodes. You see here the L from the left side, of course, and then here you see that's Dutch, so I don't think you can read it, but these are the anatomical regions where those depth electrodes were pointed to. So, and you see here the anterior insula had 3 depth electrodes. The posterior insula had 2 depth electrodes with the depth electrode in the hippocampus. and 2 depth electrodes in the temporal lobe and the lateral temporal lobe. Here you see the number of contact points of those depth electrodes. And what we saw during the seizure registration was that all seizures started on this electrode, on LT. And this was an electrode I show you on the next slide in T1, coming from dorsally to more ventrally. And especially those contact points, 7 to 18, were thought to be the seizure onset. Well, this was the scan after implantation. We do it 1 day after. And here you see this electrode. This was the electrode LT. Here you see from, these are the oblique ones going to the insula, the 3 to the anterior insula, and 2 in the posterior insula, and the 3 oblique electrodes for the hippocampus and temporal lobe. Well, we thought, okay, now perhaps we have a temporolateral focus, so neocortical focus. Nothing came from the hippocampus, and there was no seizure onset in the entire insula. So then we had the strategy, okay, this man is right-handed, his left temporal lobe is dominant. Perhaps for both focus, more near focus delineation and also language localization, we will use subdural electrodes. And then we chose to have a 32 contact point grid to cover the left temporoparietal occipital region, so this transient zone. Above that, a 16 contact point grid to cover the frontoparietal operculum, and a 4 contact point strip towards the central region. This was the scheme we made, so the 32 contact point grid here in the temporal lobe, starting at 4 centimeters from the temporal pole. Then here is the 16 contact grid. And you see here the trepanation. You can appreciate here the Sylvian fissure, the frontoparietal occipital transient zone, and the temporal lobe with the labae. And here are the grids implanted, the 32 grid contacts, the 16 contact grids, and here is the strip towards the central region, because this patient also had in one of his seizure types a sudden paresis of his right arm. This was the scan after implantation. And here you see the localization in BrainLab. We are using BrainLab for the SEEG, the localization of the depth electrode LT, number 7. That's where this point is and where you see the crosshairs. It's this electrode coming from dorsally to ventrally. And number 7 to 18 was very active during seizures. So when you fuse this with the CT, you see the grid, you see the depth electrodes, and you should look at this crosshair here. And then we project this on our scheme, and that means that LT7 to 18 was comparable to the grid number, contact number 24 and backwards. So this depth electrode was comparable to those contact points on the 32 contact strip. Well, then we had the registration phase. Here you see the interictal activity. And you see here on grid number 22 and 23, so that's the most red color, there is continuous activity, epileptiform activity, so in between the seizures, so interictal activity. And then we have on the numbers 31 and 32, these numbers here. So there is almost continuous spread, epileptiform spread, and in a bit less to the numbers 11 to 14. So keep in mind, this is interictal information. Here is the ictal information. That means that the numbers 22 and 23 are always involved in the seizure onset. So that was quite comparable with some contact points on our depth electrode. And the numbers 31 and 32, even as 13 and 14, were also involved, but not always. Then after the registration phase, we did a grid stimulation phase. And here you see also in Dutch, I try to translate for you. In green, you see language area, so Broca, Wernicke. You see motor. Before the central sulcus here, there was the motor cortex of the face area. Here was some tinglings in her face area also when you stimulated this. Visual problems she had here. And when we stimulated this part, there was a seizure. And that seizure spread to those electrodes, to those contact points. Okay, then we had to make our resection plan. And that was like this. This was the suggestion to the patient. We take out, well, remember those 4 centimeters of temporal pole. Then all the red contact points on the 32 grid. And that was a complete overlap of our depth electrode, LT 7 to 18. We spare, of course, the language areas. And we do not enter the frontoparietal area because it was temporal lobe epilepsy. And because the left hippocampus was not involved in the seizure onset, we knew that after the SEEG, we had the discussion that we spare the hippocampus. So this was the resection. So you see the temporomesial structure is still in place. And the temporal lobe, the lateral temporal lobe, which was indicated after our grid registration and stimulation, was taken out. So a tailored lateral neocortical resection. And this was an MRI 3 months later. Here you see the axial images on different slices with the sparing of the temporomesial structures. The sagittal images with clearly the hippocampus in situ. And what was the outcome of this patient? He had an Engel 1 outcome, 60 months with follow-up now on ELA class 1. Histology showed the meningoangiomatosis. He had no language deficits. He had a contralateral right-sided superior quadrantanopia, so that's quite normal when you go far dorsally in the temporal lobe. 3 years after surgery, he received his driver license back. He was very happy, and he told us that his quality of life was quite improved. So that was the second case. This was a very much more complicated case than the first one. And well, I think I'm now at the end of my presentation, and perhaps there are questions and there will also be answers.
Thank you, Olaf. There is a question about the first case. What would you do in case of a normal post-op MRI after lesionectomy, but seizure recurrence?
Well, then the patient will be in the circuit back again in our working group. And that means that there will be a new video EEG. Of course, we do in all patients, we do a MRI 3 months after surgery. So we knew, we would know that the lesion would be taken away. So then you have a new phase 1. And most probably, because we are quite SEEG minded, there would be a new SEEG procedure just to know if well the resection borders could give this well recurrent seizures. But it completely depends, of course, on the fact if those recurrent seizures are habitual seizures, which the patient recognized from before, or that are new seizures with new indications for other areas in the brain.
Okay, thank you. And about the second case, you have focused mostly on insular SEEG. Oh, what I found was also very nice, maybe to share with the audience, is the insular EEG. It's I don't know, the oblique trajectories, where you can nicely appreciate the different insular gyri. You have these three short anterior gyri and the two long ones, and you've put electrodes in all of these gyri, which was quite nice in my opinion. But that was not the question. However, am I correct? Haven't you explored the amygdala, which was suspicious for any pathological MRI? And why did you not investigate the amygdala? Do you think if you have placed orthogonal SEEG through the temporal lobe, you would spare another explorative surgery with grids? So indeed, you did two explorations. And I think the question is whether if you would have placed orthogonal SEEG electrodes, that you could have, well, that there wouldn't have been a need for a subdural grid exploration.
Yeah. So the last question, perhaps first. That's correct. So, we have quite an extensive group of neurologists, epileptologists in our team and neurophysiologists. And one part was trained from the first instance on in the SEEG, and the other part was trained more with the subdural electrodes. We still have the feeling that when you really want to delineate the language areas on the temporal neocortex, that we need a grid electrode. I know that when we speak to the French colleagues and the Italian colleagues, that they say, okay, now when you do an SEEG tailored in the complete temporal lobe, you also can examine language function. So I think that's just a point of experience. So our neurophysiologist at that moment was more experienced with grid electrodes to delineate the language function. So we followed that advice. But as there are more ways to roam, I think that, when you have more than 50 years experience like the French colleagues of SEEG, I think you can also use orthogonal depth electrodes indeed to delineate the language areas. That's true. So, and the first question, short answer, of course, we took away the part of the lateral amygdala, but the diagnosis was gliosis. So there was nothing specific in this part of the amygdala.
May I ask you another question, Olaf? Do you think that this second case would have been a case for awake surgery?
Yeah, I was going to ask the question. I would probably also propose awake surgery in these cases. Yeah.
Yeah.
I was going to ask the same thing.
Yeah, that would also be a possibility. Then we had to translate, because the depth electrode was, of course, in the depth of the temporal lobe. But yes, I think that would be a possibility. Yes. So there is always a possibility, I think, to do Penfield resection or a grid. So in this case, they wanted to delineate more the epileptogenic focus also, because you remember it was this lateral depth electrode 7 to 18, but to transfer this back to the cortical surface, that was not so easy. So they wanted to have also a focus delineation, but when that was not the case, just for the language, we could have done a Penfield, yes.
Yeah. Maybe a follow-up question to this. Do you use bold fMRIs for speech delineation in such patients? And do you use this information, if yes, for the neuronavigation?
We use fMRI, but we are only confident with this technique to say which is the lateralization of the speech, not the localization of the speech. So we don't trust the fMRI till now that it localizes quite well your language areas.
Yep. In this case, maybe it would have been an option to do a bold fMRI and compare it with the stimulation sites of the extra operative language stimulation on your grid.
Yeah. That's a good tip, yes.
But then the ground truth will still be the subdural grid anyways. I mean, it's superior to fMRI, the direct stimulation.
Problem is eventually in kids.
Sure. Yeah, operated it. It's true. In kids, it's definitely difficult. Yesterday, by accident, I operated a left insula lesion, and there we did a resting state language, fMRI. I don't know how trustworthy these are, but we did it, and there was a bilateral activation. The kid is speaking today, so I'm happy. But it's it's doable. That kid was 5 years old, and there it's difficult even to do like a functional MRI task based. Yeah, it was also, I think you can do this, well, awake. I don't think you have to do this case awake, but if it's more posterior or if it's frontal, I think it's preferably done awake because then you have to do subcortical mapping, which you cannot do with the subdural grid.
Yeah.
No?
Yeah.
But this is more anterior, so probably it's safe also to do it this way. I don't know if there's any other. Yeah, there is another question. What management strategy would you advocate in case of delayed postoperative seizure recurrence with generalization of epilepsy on PET or MEG? A difficult question. So which management strategy would you advocate in cases of delayed postoperative seizure recurrence with generalization of epilepsy on PET or MEG?
Well, I think you should go back to the beginning. What is the seizure semiology? What are the symptoms the patient is having? Is that we always say, are the habitual seizures, asking the patient and their family, or not? When it's new symptoms, other seizures, then most probably we would have a look. What kind of examinations did we do in phase 2, so non-invasive, and with which kind of examination didn't we do, and is there a possibility to do these again? And again, so most probably when you think it could be a second focus, we will do a redo stereo EEG.
And I have one more question on the first case, which was interesting in my opinion because it was a layout with the BRAF mutation. And as you know, there have been a few recent publications, also by Daniel Denlev, who says that these BRAF mutated cases tend to have like a higher likelihood of recurrence. Is there anything else you do in these specific cases? You know, if there are BRAF mutations in the follow-up of these patients, even if there is a total resection?
Yeah, well, you know, there are some reports saying that the recurrence rate is higher. And of course, we know we also had one case in our series that's doing epilepsy surgery now almost 25 years. We had one case that's a ganglioglioma de-differentiated into a glioblastoma. So that's terrible, of course. So we know that it is possible, and therefore, till the literature is more is a bit larger, I would say that the recurrence rate is not influenced by this BRAF mutation. So till that moment, we have the strategy to control a patient once a year, the first 5 years, and then the second 5 years, we do every 2 years an MRI scan. And after 10 years, nobody knows. So then I think it really depends. Is a patient still seizure free? What is the character of the patient? Can he or she, be in a psychological good state to go on without controls? So nobody knows. but at this moment, we have the intention to control every year. But till now, I have several gangliogliomas with the BRAF mutations. Until now, I didn't see any recurrence. So, but well, let's follow the literature, and I don't know what the experience you both is about this.
In Erlangen, I had 2 patients who were primarily ganglioma grade 1, and they metastasized, and both died. One had even lung metastasis. And recently here in Vienna, I had a patient, it's 2 years ago now, 2.5 years ago. He had a large temporal lobe tumor. It looked like glioma. It also had a contrast enhancement, but it turned out to be a ganglioma, and they said grade 2 to 3 with a BRAF mutation and a TERT mutation. And I could resect it completely, but they recommended radiotherapy and temozolomide, like glioblastoma. And he did that, and of course he's seizure-free now, but he's also tumor-free now. But nobody knows if it was a overtreatment or not. I was not so sure, because there was this methylation analysis, and it said ganglioma, yeah. And
Okay.
there was a higher MIP index, higher proliferation index, but there was this TERT mutation, and which means also it could be a more malignant case. So I think there are some cases like this, but nobody knows at the end what to do. And normally they get the whole treatment,
Yeah.
like this guy, chemo and radiotherapy.
Yeah, you stayed more on the safe side. Perhaps that's good.
Yeah.
So, and what about the follow-up imaging? Do you also do once a year an MRI when you have a BRAF
This
mutation?
guy has now every 6 months MRI.
No, but in general, when you have a
In general, once a year.
Yeah,
In the layered cases, once a year.
yeah. And you, Tom, you also do
Yeah,
that?
same thing. But yeah, with these BRAFs, yeah, it's just since this I read this paper, and since then we are a bit more cautious, let's say. But not that we have strict protocols for this. So that's why I'm asking.
Yeah. So till now, I think I followed eight or nine gangliogliomas with the BRAF mutation over, I think now 3-5 years, and I didn't see in any patient a recurrence. But okay, that's nothing. So you need large numbers. So I think literature will help us in time.
Yeah, I think we went through most, if not all, questions. Wait, no, there's one more. Sorry. Do you use combined fMRI EEG acquisitions for the localization of interictal IEDs and indirect localization of the seizure onset? So EEG fMRI basically is somebody still using this? Somebody?
Yeah, in our center we use it, not in every case, but it is used, EEG fMRI. Yes.
Yeah, we also have established it now, and we use it in rare cases, or we are just at the beginning of using it, yeah, I would say.
But not in the most
Not in
of
the
the
routine
temporal lobe
setting.
epilepsy cases are not generally not it's not recommended. Yeah, one more thing, maybe a recent entity is also the temporal encephalocele. So it's something which has not been, well, has been missed probably in the past. It's something, well, recently we did a few of these surgeries. Not sure what your experience is with these cases.
We had a series of 10 patients. They are still not published. They are in Erlangen. Burkhard Kasper is the neurologist. He has the data, but we had a poster on it. And in these cases, we did just pole resections and resection of the encephalocele. And 7 or 8 of these 10 got seizure-free.
Yeah, that's what I was going to mention. These patients seem, well, I don't have a huge experience, seem to do very well. So it's important to, stress this because it's something you can easily miss. And once you see it, you start seeing it. It's like they can be very big, these encephalocele. So it's something to, well, take into account when you're looking at scanners, because it can be easily missed if the neurologist isn't aware of this entity.
Yeah,
that's
relative
important.
new entity with a good outcome. Yes.
Mhm.
Yeah, very good outcome with easy surgery.
Exactly.
Yeah, there's a question about encephalocele and lid. I have well,
Yeah,
I'm not
there
sure
are
if that is the
some,
best,
yeah.
indication for a lid or disconnection to avoid a leak. Yeah, I usually place like some muscle or fascia of the muscle on, on the skull base of the middle fossa skull base. So I think it's a quite straightforward surgery, and I think with a lid, it's probably a bit difficult also to
Yeah,
do it.
sometimes these holes in the skull base,
Yeah,
they are
always.
very next to the sphenoid sinus, and and it is recommended, I think, to place some autologous tissue that you get a good coverage and not to get a CSF leak or something like that.
So I think, well, until further studies, I would also propose open surgery and
Yeah.
cover the defect in the middle fossa.
Yeah.
Yeah.
Agree.
Okay. I'm just checking, but I think we tackled all the questions. So I want to thank both of you for the very nice presentation, and thanks everybody for joining this session.
Thank you for the information, Tom.
And for the discussion
Thank you
also.
very much.
Have a nice evening,
you.
and until next time, I would say.
Yeah.
Okay.
See you.
Have a nice evening.
Good
Bye-bye.
night.
Bye.
Bye-bye.
Nice evening.